This is a sample diagnostic approach to dyspnea in the emergency department. Shortness of breath is a very broad term that has a very large differential. Therefore, in order to help narrow that differential, this lecture talks more specifically on patients referring to feeling short of breath in their lungs. Therefore, it excludes upper airway processes, paralytic disorders such as Guillain-Barré, or compensatory processes such as Kussmaul and DKA. Since dyspnea is not a painful process, you cannot use cold-or-as or PQRST mnemonics to help describe the dyspnea. However, here are some characteristic features. Duration can be used, such as time of onset and whether it is constant or intermittent. If it occurred suddenly or gradually. Initiating or exacerbating and relieving factors are important, such as exertional, pleuritic, or associated with laying flat, which is defined as orthopnea. If you wake up short of breath or gasping for air, it's called paroxysmal nocturnal dyspnea, which is classically from pulmonary edema or sleep apnea. But if you have PND and orthopnea, it's classically from pulmonary edema. If they also have rhinorrhea, I usually have to clarify if it's the coughing that wakes them up at night, hence from postnasal drip, or if it's actually from being short of breath. For important associated symptoms, you can see the later slides.
For the differential diagnosis of dyspnea, I made the mnemonic heart PCI, since CHF is a common cause of dyspnea, which is typically caused by patients with a prior history of cardiac interventions for heart attacks. H is for hemoglobinopathies, which is classically anemia, but do not forget carbon monoxide poisoning and methemoglobinemia. This can also include cyanide poisoning, which I don't discuss in this lecture. Pulmonary edema is most commonly from CHF. However, remember that other etiologies such as ARDS, high altitude pulmonary edema, pulmonary contusions, high output heart failure, and aortic stenosis can also cause pulmonary edema. I use the term reactive airway disease to reference COPD and asthma. Just like in chest pain, I clump tension pneumothorax and pneumonia together, as they are typically worked up the same way with a chest x-ray. Pulmonary embolism, cardiac tamponade, and myocardial ischemia are also in the differential. As a disclaimer, these algorithms typically exclude pediatric and pregnant patients. This slide has a sample medical screening examination algorithm that can be done in triage when there is not enough time or space to do a full exam. This slide tends to be more useful for NPs or PAs, as medical students are usually with residents that are doing a comprehensive evaluation. Of course, with every patient, you have to remember your ABCs. If they are unstable or have a STEMI, or objectively in distress or uncomfortable, cyanotic or hypoxic, or in need of acute care, notify your attending and perform basic resuscitation efforts. In general, everyone gets an EKG and chest x-ray. I tend to use absolutes, but realize that there are always exceptions. Some patients may have a clear diagnosis and currently asymptomatic and so do not need a chest x-ray. As well as asthmatics deserve special attention, as while plain films do not have significant amount of radiation involved, asthmatics tend to get a lot of chest x-rays and so need better clinical decision making for huge utility of chest x-rays. Bronchospasm in the ED tends to be a clinical diagnosis. Bronchospasm starts with end expiratory wheezes and progresses to the entire expiratory phase and then inspiratory wheezes. However, be aware that they may be so tight that they are not moving any air, in which case you will not hear any wheezes. This severe bronchospasm can be tough to distinguish from a chronic COPD that has horrible air movement at baseline due to chronically destroyed elastic tissue. In any case, if I do not hear wheezes because of poor air movement, typically I give a breathing treatment and reassess their lungs to see if they opened up at all. The standard treatment for COPD or asthma exacerbation is Duonev and a steroid. Magnesium has been questionable efficacy and typically used in more severe exacerbations, therefore not included in the MSC flow, but you'll see it on the comprehensive algorithm. The decision with asthmatics tends to be whether or not to get a chest x-ray. A suggested criteria on up-to-date is if initially you hear focal breath sounds, they have a high fever over 39 degrees Celsius, or having a severe exacerbation, going to do a chest x-ray. Otherwise, you treat and reassess, and if after treatment they are still tachypnic, hypoxic, or still have chest pain, then you get a chest x-ray at that point. Peak expiratory flow rate is mentioned in the literature as being a useful value before and after treatment to guide management and diagnosis. However, it has limitations, as mentioned in the 2013 EB Medicine article on asthma, and I have not seen it used much in the emergency department. Conversely, all COPDers get a chest x-ray because they tend to be older and have much higher pretest probability of complications such as pneumonia and spontaneous pneumothorax from blips. The decision in a COPD exacerbation tends to be the use of antibiotics for COPD bronchitis, which is the only bronchitis that tends to be bacterial. The generic suggestion is to use antibiotics such as azithromycin for any change in sputum production or in severe exacerbations. Of course, other questions in COPD or asthma exacerbation is whether or not some other process is going on, as wheezes can present in pulmonary edema or PE as well, which we will discuss later. On to anemia. The comprehensive algorithm is very vague, stating that any concern for anemia should get a CBC. However, in the MSE, I try to be more direct and try to catch the patients that may need a transfusion sooner than later, which would include someone who is pale appearing or have any current bleeding, even menses, because a patient's account of the severity of their flow can be variable. You cannot calculate a heart score without a troponin. However, I use the rest of the scoring system to help guide whether I order troponin or not. If the heart score is otherwise 0, then it is unlikely that the troponin will change your management. Just realize that your suspicion for cardiac disease goes into the score as well. Also, remember that the heart score was derived for patients with chest pain, not dyspnea. The workup of PE is pretty thorough and takes a lot of experience and not easy to do in triage. However, adding a dimer after everything has returned can delay their dispo by an hour or so. Therefore, I include some specific scenarios where dimers can be ordered from triage. Just realize that a positive dimer can cause some significant problems in management, especially if their renal function is abnormal. So if you do not feel comfortable ordering a dimer, then do not order it. This will hopefully give a couple scenarios that you can start ordering it and therefore start getting used to its utility. I picked the higher risk patients from Wells and PERC rules, such as clinical signs of DVT, recent surgery, or active cancer as patients to be concerned for PE. Tachycardia is the most common EKG finding in PE, so it should make you think of PE. However, there are a lot of patients with tachycardia that do not have PE, so do not be ordering dimers on every tachycardic patient. If they have one of these concerning findings for PE, then check if they are on anticoagulations or have abnormal renal function before ordering the dimer. Those that are already anticoagulated are a different scenario, and everyone approaches it differently, so let that medical decision making be made during the comprehensive evaluation. You do not want a false positive dimer if the kidney function is abnormal, so check what their kidney function was recently, and if it was abnormal or you do not have a prior labs, then do not do the dimer. I just chose an arbitrary term or a time frame of 1 year to look back for any labs that you see in the last year that show a normal kidney function. Lastly, if they have an associated headache, smoke exposure, or a group presentation, then you can order a VBG with co-oximetry for carbon monoxide poisoning. I did not include methemoglobinemia for the MSE because if they are hypoxic or cyanotic, they should get a prompt comprehensive evaluation. This is a more comprehensive diagnostic algorithm for dyspnea in the emergency department. Again, if the patient needs prompt attention, notify your attending or supervising resident and manage the ABCs. Nearly everyone gets an EKG as well as a chest x-ray that is described later. If you have a concern for MI, then you can give aspirin, just like in chest pain, but only in those that you will not be working the aortic dissection up and those who do not get anaphylaxis from aspirin. The COPD and asthma algorithm is the same, just with 2 grams of IV magnesium added for those who have a severe exacerbation. This is typically for asthma, but I have heard a few resources say you might as well try it in COPD. While there is limited data for the benefit of magnesium causing bronchodilation, 2 grams is relatively safe, hence why you might as well try it when they're in a severe exacerbation. Like we said, almost everyone gets a chest x-ray for pneumothorax or pneumonia, except for some asthmatics. This can also evaluate for pulmonary edema. Just realize that while CHF is the most common reason for pulmonary edema, there are other reasons for pulmonary edema. Most of these other reasons are resuscitated in the emergency department and then either worked up out of the emergency department or have a different presentation, such as high altitude pulmonary edema or traumatic pulmonary contusion. Do realize that pulmonary edema on chest x-ray can be a delayed finding, and some patients chronically have evidence of pulmonary edema on chest x-ray, making the acute diagnosis of CHF difficult. BNP has been used to try and objectify the diagnosis. However, it has significant limitations that we can discuss later. In general, if your gestalt is low and the BNP is less than 100, CHF is unlikely. If it is over 500, then CHF is likely. Otherwise, it is indeterminate. However, patients with CHF tend to have chronically elevated BNPs. Therefore, everyone has a different way of using BNP, and some practitioners do not even use it. Personally, I do not feel that you are right or wrong if you order it or do not order it, as long as you know how to interpret it. The times I find it most useful is to help with an admit or if they have a history of troponin leak during CHF exacerbations. Realize these cutoffs are for a BNP and not a pro-BNP that has different cutoffs. The algorithm for PE is the same as we discussed in chest pain and can be discussed more later. There's not much data in the workup for MI in patients with dyspnea without chest pain, so it just goes with your suspicion. But like I mentioned in the MSc flow, I tend to use heart score to help me. Any concerns for anemia gets a CBC. There is no history or exam findings to rule out anemia, so it is not uncommon to order blood work on all dyspneic patients. However, not all anemic patient needs intervention such as blood transfusions, and not all anemic patients are dyspneic from their anemia. So a conservative strategy is to order a CBC on all dyspneic patients. However, if you want to be resourceful, you can try to only order it on patients that are likely going to get intervention. Any patient with cyanosis or concern for carbon monoxide poisoning should get a blood gas with co-oximetry. As stated in the chest pain lecture, a conservative approach to cardiac tamponade is to do a bedside ultrasound on everyone who did not get a CT scan. Now we will start discussing each individual diagnosis. EKGs are very cheap and easy tests that give a lot of information, and so should have a low threshold for ordering them. Here is a slide I made to help test your knowledge of different arrhythmias. Feel free to pause the video to help quiz yourself. Think of the diagnosis and the treatment. However, I always find it difficult in an emergent setting to mentally jump from an image to the diagnosis to the treatment. Therefore, I made mnemonics on how to jump straight from the picture to the treatment, because when someone is coding, you need to be able to call out the intervention that you want without having to think about it. Okay, think about the first one. 3, 2, 1. This is atrial fibrillation because it has an irregular rhythm without any discernible P waves. I picture a letter on each chaotic P wave to remember A, B, C, D, where A is atrial fibrillation and the rest is medication for rate control. B is beta blocker, C is calcium channel blocker, and D is digoxin. However, the medication that I find most useful is diltiazem, brand name Cardizem, which can also be used for the C and D in the mnemonic. Okay, go to the next one. 3, 2, 1. This is textbook atrial flutter with the sawtooth P waves. The same mnemonic can be used with the sawtooth P waves, as it is treated the same as atrial fibrillation. However, atrial flutter does not always have the sawtooth P waves. More commonly, I see the 2-to-1 conduction, where the P waves look normal and the P waves conduct at 300, and only half the P waves conduct to the ventricles, making the ventricular rate about 150, give or take 20. Think about the next one. 3, 2, 1. This is SVT, which is treated with adenosine. SVT has a fast P that conducts the QRS. So since there is always a P wave paired with the QRS, I see a plus sign adding the P and QRS together to remind me of adenosine. As a side note, this SVT at a rate of 150 is indiscernible between atrial flutter 2-to-1 conduction if the non-conducting P wave is hidden in the QRS. So it is important to march out the P waves to see if the non-conducting P waves can be hidden in the QRS. This differentiation is better explained in my EKG lecture. Okay, the next one, 3, 2, 1. This is WPW, which can present in many different fashions, so please refer to my EKG lecture. However, it classically has a delta wave, making the QRS wide and the PR interval short. I visualize the delta wave as a steep hill requiring a professional cane to walk up. Therefore, the treatment is procainamide. Okay, the next, 3, 2, 1. This is ventricular tachycardia, a fast, regularly wide QRS. If unstable, you electrically cardiovert, and if stable, they can be chemically cardioverted. Think about the next one, 3, 2, 1. This is ventricular fibrillation, which is always unstable, so it gets electrically cardioverted. I do not have a good mnemonic for these last ones. Think about the last one, 3, 2, 1. This is torsades de pointes, which is treated with mag sulfate, if stable. However, you can cardiovert it if unstable. This is usually caused by a prolonged QT interval, which is why it is treated with magnesium, as low magnesium causes a prolonged QT. Low potassium and calcium also cause a prolonged QT, which can also be treated with magnesium. COPD and asthma exacerbations were already well addressed on the algorithm slides. An important point to remember is that severe bronchospasm does not move air and therefore does not have wheezing, of which is an ominous sign. Realize that wheezing does not rule out other diagnoses. Patients with COPD or asthma may have intermittent wheezes and need the rescue inhaler periodically on a normal basis, and may coincidentally have some of those wheezes on examination. PE can also trigger a COPD exacerbation. I usually put it all into context, as if someone is significantly hypoxic at 79% Romer and in severe respiratory distress, but their lungs have good air entry with mild and expiratory wheezes, it's unlikely that their severe dyspnea is due to a COPD exacerbation. If it helps you, a definition for COPD exacerbation is someone with a history of COPD who has an acute change in their shortness of breath, cough, or sputum production. This may require a change in the medication, such as a short course of steroids and sometimes antibiotics, as discussed in the algorithm. Typically, a 5-day course of prednisone is given. However, I tend to give a dose of 8 or 10 milligrams of Decadron in the emergency department, and then a second dose of Decadron in 2 days for a theoretical improved compliance. Pneumothorax and pneumonia is typically evaluated with a chest x-ray. This is the same slide as in my chest pain lecture, so refer to that lecture for more of a description. Here are a lot of likelihood ratios for an acute CHF exacerbation. I tried to highlight the useful ones in red, almost useful ones in green, and stroke through the ones without statistically significant confidence intervals. You can review these tables to get used to useful questions to ask. I'll highlight on some of them. If they have a past medical history of CHF or MI, it can increase your suspicion. If they have some coronary artery lesions but never had intervention for MI, such as stent or bypass grafts, then it is not useful, which makes sense because they are unlikely to have any infarcted tissue. Prolonged hypertension can cause CHF, but does not change your suspicion for acute CHF, probably because hypertension is so common. None of these can decrease your suspicion. On exam, S3 gallop, JVD, crackles, and lower extremity edema can be helpful if present, but not helpful if absent. Do note that presence or absence of wheezing does not change your suspicion, as we mentioned previously. Paroxysmal nocturnal dyspnea and orthopnea is almost useful if present. Dyspnea on exertion is not useful, likely because other etiologies cause this as well, including COPD, asthma, pneumonia, and MI. The absence of dyspnea on exertion is also not helpful, but close to the 0.3 cutoff. When looking at likelihood ratios, it is easy to get discouraged and wonder why we ask these questions if they are not useful. There is no single characteristic that can be a gold standard standalone test. However, when you start incorporating multiple factors together, we start getting useful decision tools. The heart score is a great example. The troponin is not a perfect test, and so cannot be used in isolation. However, when combining multiple characteristics, we then produce tools like the heart score that is clinically useful. As you can see in this bottom right table, a low gestalt for CHF and a negative BNP has a negative likelihood ratio that can almost rule out the diagnosis. Unfortunately, the features that go into the gestalt are not formally documented and so difficult to teach. It takes time to develop, and it's hard to validate. The negative BNP alone also can almost rule out the diagnosis. However, false positives do occur. I've heard specialists state that BNPs rarely change management. When you know it's not CHF, it's negative. When you know it's CHF, it's positive. And when you're unsure, it's indeterminate. Therefore, it does take time to develop your own method on how to use it. Gestalt alone is borderline useful. Chest x-ray findings are helpful when positive, but not present. It still could be CHF. I have seen chest x-ray findings lag symptoms by several days. Like we just acknowledged, 19% of acute CHF exacerbations have a normal chest x-ray. We discussed BNP a lot already. Procalcitonin is something in the works to try to differentiate an opacity from pneumonia versus pulmonary edema. However, it has not made its way into the emergency department literature yet. One article stated chest x-ray and lung ultrasound having mild to moderate sensitivity and specificity alone, though improved sensitivity when used together. It also supported a good sensitivity to the BNP, but with poor specificity. The conclusion of this article was to suggest using a stepwise approach to start with chest x-ray and bedside ultrasound to get a low-risk group, and then using BNP to further decrease the likelihood of CHF without causing as many false positive BNPs. However, this approach is not validated. Furthermore, if you are using ultrasound, you should do a bedside echo to look at their EF and IVC as well. Though these details are a bit beyond the scope of this lecture, as it takes an above-average training on ultrasound to perform. I just mention it here to reiterate the point of not relying on a single characteristic or test. Rather, try to incorporate multiple features to help come to your diagnosis. The workup for PE is the same with dyspnea as it is with chest pain, so feel free to refer to my chest pain lecture for more of a discussion. I will just reiterate that the research states this algorithm is for those who have a concern for PE, which does not mean that every patient with chest pain or dyspnea need to be assessed with this algorithm, but it does not define how to know whom has a concern for PE. In my practice, I tend to use this algorithm in patients that I have a gestalt for PE or that I do not have an objective diagnosis for. If it sounds like pneumonia and they have an obvious pneumonia on chest x-ray and a fever, then it is probably pneumonia and not PE. Just remember that nothing is perfect. The specificity of chest x-ray for pneumonia is only 59%. Therefore, I make sure to do shared decision making whenever appropriate and always give strict return and follow-up instructions. I will usually explain why I think it is what I am diagnosing them with, and explain that nothing is perfect, and so give strict return and follow-up instructions. That way, if they feel like this is not pneumonia or whatever diagnosis I am suspecting, then they can communicate that to me, and we can then work up PE. Just remember that if it sounds like cardiac, we usually don't get an objective diagnosis for this in the emergency department, and so I will usually work up PE for those patients, or explain to the hospice that I did not do the workup given abnormal kidney function and did not want to leave them with a false positive dimer that they are forced to address. This is some pointers on my Gestalt for PE, but everyone has their own approach, and it is your job to develop your own as well. This is everything that I found on MI presenting with dyspnea alone. And it just states shortness of breath can be the sole symptom of stable coronary artery disease. However, no information to help determine how to work those up. I tend to use the same approach as I do with heart score and chest pain. I do not tend to admit as many patients with dyspnea for a cardiac workup as I do chest pain. However, if they have a good history of exertional dyspnea without another diagnosis found in the emergency department, then I may talk to the hospitalist. However, these tend to be fairly difficult admits. Just remember that atypical cardiac presentations do occur, especially in females and diabetics, so keep this diagnosis in mind. There is no way to rule out anemia based on history or examination. However, the resources I found did not single out clinically significant anemia. Many are anemic and do not need interventions, such as blood transfusions. A conservative approach would be to order CBC on every dyspneic patient, being aware that anemia can be a delayed finding. However, trying to use discernment about who are more likely to need intervention for anemia may be a more efficient approach, but ill-defined. In general, associated symptoms include headache, chest pain, dyspnea on exertion, postural dizziness, and exercise intolerance or fatigue. The most common etiology is some kind of blood loss. There is also peptic ulcers, anti-inflammatory use, trauma, melena, menorrhagia, hematuria, hematochezia, hematemesis, or anticoagulation use, which are all related to blood loss as well. This table has different exam findings for anemia, which you can parse through to find the ones you like the best for your examination. However, they are only useful if present and not useful if absent. Carbon monoxide poisoning is important to diagnose because the mortality is 30% and the exposure can often be from their own home, such as burning fires in their own home. Therefore, they look and feel better in the emergency department but are discharged back to the environment that they can continue to get poisoned at. The classic scenario is when the patient and everyone they live with, including their dog, has flu-like symptoms. Typically, the initial symptoms that occur are headache, dizziness, fatigue, and nausea or vomiting. After longer exposures are when you get dyspnea and chest pain. The more severe symptoms include an organ damage such as confusion or loss of consciousness. Therefore, I typically order co-oximetry in patients with an associated headache or in those with smoke exposure or multiple sick contacts. The treatment is oxygen therapy and removal from the environment. Diagnosis of carbon monoxide poisoning is made if the carbon monoxide hemoglobin level is over 3% in a non-smoker or 10% in a smoker. The most aggressive treatment is with hyperbaric oxygen. However, the indications for hyperbaric oxygen is controversial and based on very poor data. A suggested indication is carboxyhemoglobin levels over 25% in non-pregnant patients and 20% in pregnant patients, as fetal hemoglobin has a higher affinity for carbon monoxide. Other indications for hyperbaric oxygen levels is signs of an organ damage such as loss of consciousness, syncope, seizure, coma, pH less than 7.1, fetal distress, MI, or neuropsych such as mood changes. I remember methemoglobinemia best by remembering the antidote methylene blue, and therefore is a diagnosis with abnormal colors. Patients present blue or cyanotic, and they have chocolate brown blood, which artificially shows up on the oxygen sat monitor as 85%, which does not change with administration of oxygen. Patients get similar symptoms as anemia or carbon monoxide poisoning, such as headache, dizziness, nausea, anxiety, dyspnea, chest pain, tachycardia, confusion, seizures, coma, or death. Classically, this is caused by someone with G6PD deficiency that is exposed to a new drug. This can occur from local anesthetics such as applying too much benzocaine spray when doing a peritonsillar abscess drainage. These other drugs can also cause methemoglobinemia as well. Lastly is a slide on cardiac tamponade, which is the same as presented in my chest pain lecture.
And here's a copy of all my References.